Well, thank you very much for attending this small presentation of a case that I found very interesting. And definitely I learned something. And I hope you enjoyed it as much as I did. So the clinical history is that of a 43-year-old male. And I'm going to turn off the camera so you can guys focus on the presentation, and I will reappear at the end. In 2009, he had an MRI for some back pain, and a paraspinal mass was identified, which measuring 6 to 7 centimeters at that time. Initial biopsy was done, and it was reported as benign by the outside institution. However, these slides were not available. In 2022, the patient had increased back pain, and a repeat MRI and CAT scan revealed an increased mass of increased size, 8.3 centimeter in greatest dimension, with also 2 additional lesions near the left psoas and under the left hemidiaphragm. At the end of 2022, at a repeat MRI, which showed a significant growth of this mass, measuring 15.9 centimeter and suspected invasion of the left transverse process. There were multiple similar lesions that they were likely representing metastasis affecting the T12 to L5 paraspinal region. The CT chest and abdomen noted a pleural and extrapleural mass and retroperitoneal adenopathy suspicious for metastasis. The patient came to our institution, and we requested the slides from the outside institution as required by our QA policy. And this is the material that we received, just the slides, which shows a core biopsy with a tumor which is very hypercellular, looks very blue, with growing in seeds of cells that they have minimal cytoplasm, and also in between you actually can see fibrous collagenous tissue bands. On high power magnification, we see that the tumor is quite uniform. The chromatin pattern is quite fine with intranuclear inclusions without any prominent nucleoli. There is no pleomorphism, increase a lot of mitosis or necrosis, and there were interspersed capillaries. In other parts of this biopsy, the cells appear to be a little bit less cellular with more eosinophilic collagenous background. There are some microcystic changes or pseudoalveolar changes or pseudovascular changes lining by these hyperchromatic small uniform cells. A lot of immunohistochemical studies had been performed at the outside institution that they were all negative: STAT6, HMB45, melanA, keratin, SOX10, S100, CD34. They're all negative immunohistochemical stains. The proliferation index by KS67 was approximately 20 to 30%. However, there was a PATZ expression of desmin. S100, as I said, was completely negative. CD99 was completely negative, and myogenic was completely negative. However, this tumor was diffusely positive with moderate intensity for MyoD1. The outside institution has sent this case to a very famous academic center in the United States, specializing in bone and soft tissue pathology, who rendered the diagnosis as a typical round cell neoplasm suggestive of sclerosing rhabdomyosarcoma. This patient then, as I said, came to our institution for another opinion. We reviewed the slides, and our diagnosis was consistent with sclerosing rhabdomyosarcoma. This is a T1 MRI sagittal, just to show how monstrous this mass was, about 15 centimeters. This patient was rebiopsied at our institution. and again shows a tumor who grows kind of in a multinodular fashion. There's some intercepting fibrous collagenous septi. The tumor appears quite uniform with ovoid, roundish, and spindle cell lesions in between this collagenous tissue. The chromatin again is very fine with indistinct nucleoli with no significant pleomorphins. There was no necrosis or readily identified mitotic figures. The cells had some kind of a bit collagenous background. Other areas, they're looking more hypercellular with seeds of round or around ovoid cells with minimal eosinophilic cytoplasm, were interspersed small vessels with a hint of halonization around the vessels. The tumor was infiltrating in between skeletal muscle. You see here, these are skeletal muscle bundles. And the diagnosis that we rendered was consistent with sclerosing rhabdomyosarcoma, morphologically similar to previous material. And then I sent it to molecular analysis since we had an in-house specimen now. And of course, that was not the correct diagnosis because the RNA-seq detected EWSR1 PATZ1 fusion, an in-frame fusion between exon 8 of EWSR1 and PATZ1 of exon 1, which was also confirmed by fluorescent in situ hybridization, showing EWSR1 rearrangement in 45% of cells. So we had to revise our diagnosis to a high-grade round cell sarcoma with rhabdomyoblastic differentiation harboring EWSR1 PATZ1 fusion. The category of undifferentiated small round cell sarcomas under the Ewing is defined under the current WHO. Tumors have round cell morphology similar to Ewing sarcoma, but they lack EWSR1 ETS rearrangements and do not have any other signs of a specific line of differentiation. And the three categories, the big categories, is the most common is the CIC rearranged sarcoma with the most common fusion, the CIC DAX4, which represents the largest subset of at least 70% of cases. The second one is sarcoma with B-core genetic alterations, and then round cell sarcoma with EWSR1 non-ETS fusions. The EWSR1 PATZ1 fusion, of course, they're not described only in sarcomas, as we have seen the last couple of decades with the explosion of NGH. These fusions are promiscuous. EWSR1 PATZ1 fusion also defined clinically a distinct group of histologically polyphenotypic neuroepithelial glioneuronal tumors of the central nervous system, and also has been described in rare renal cell carcinomas. We have this characteristic thyroid-like follicular kind of morphology. As we know, the EWSR1, FUS, and TAF15 comprise the FET family of closely related RNA binding proteins. The PATZ1 is a Zinc-Finger protein belonging to the POZ domain, group of like Zinc-Finger, POK, family of architectural transcription factors that were first discovered by 3 different groups simultaneously in 2000. And since that time, they're accumulating evidence that has shown involvement of these protein in various biological processes, such as embryogenesis, apoptosis, senescence, proliferation, etc., and of course in human diseases as well. And as I said, EWSR1 PATZ1 is at the moment a subcategory of undifferentiated round cell sarcoma. We recently wrote a review with Dr. Masato and colleagues, and this is a very nice paper that very recently was published, and then summarizing all the data that we have so far for the sarcomas harboring EWSR1 PATZ1 fusions. The EWSR1 PATZ1 tumor was first discovered, reported in 2000 by Mastrangelo and colleagues in a chest wall tumor of a 16-year-old boy. However, the credit goes to Watson and colleagues, were first recognized that EWSR1 PATZ1 sarcoma might represent a unique entity which is transcriptionally distinct by other round cell sarcomas that they are not Ewing. And morphologically, it's actually, now that we have experience of more than 40 cases, actually can show distinct morphologic characteristics. These tumors tend to be well circumscribed and surrounded by a fibrous pseudocapsule that may contain lymphoid aggregates. However, very commonly, they invade this fibrous pseudocapsule in a mushroom-like appearance. Sometimes they can actually show an infiltrated pattern. Very characteristically, they have these fibrous thick bands that is quite characteristic of this tumor. As you can see here, the fibrous bands in between the tumor cells. Another characteristic is the microcysts that are lined by tumor cells and sometimes contain proteinaceous material. This pseudo-alveolar architecture with microcystic changes is a very characteristic morphologic clue for this entity. They can have myxohyaline background, and another clue and characteristic is many times they show hyalinization of the intratumoral vessels, as you can see here. Sometimes they look more than the round cell component, the solid round cell component, but very rarely they can show only a solid round cell component. Most of the times you see a combination between round cell component and spindle cells. So that combo, they can show actually, sometimes they can show whirling, and rarely you can see epithelioid changes. As you can see here, there's epithelioid cytomorphology with prominent nucleoli. Sometimes you can see these three patterns, but to see predominant epithelial pattern is very rare. And occasionally they can show degenerative type atypia. You can see here a sarcoma that's composed exclusively of epithelioid cells, which shows degenerative type of atypia. But most of the times it's the combo between round cell and spindle cells. They can, most of the times they're surrounded by this pseudocapsule, but they can infiltrate into the adipose tissue, engulfing the individual adipocytes and mimicking adipocytic metaplasia. And tumor necrosis is not a common finding in this tumor. Sometimes you can see interspersed rhabdomyoblasts, or you can even see aggregates of rhabdomyoblasts, as is nicely illustrated in this reported case. Immunohistochemically is another clue, because this tumor shows a polyphenotypic expression. It can express S100 protein, it can express SOX10, it can express GFAP, so express markers that you see in my epithelial neoplasms. Can express desmins, sometimes is more pronounced around the microcystic changes. It can show some rare myogenic cells and more pronounced expression of MyoD1, similar to our case. And this is a summary of has been reported, plus the last paper from Dr. Denner and Fulp and colleagues. So it's the most common subtype among the EWSR1 non-ETS undifferentiated sarcoma. The second most common subtype. There are 45 soft tissue tumors reported today. The age range is wide. The affected individuals are aged from 1 to 81 years old. is twice as common in men. Predominantly arises in deep soft tissue and has a very strong predilection for the thoracoabdominal region, where about 35 cases, 83% have been reported in that anatomic location. And interestingly, the clinical behavior is quite heterogeneous. The initial cases were showing that it may be uniformly an aggressive tumor, but may have been a publication or referral bias. Seems from the case that we have so far that the clinical outcomes vary. Some cases, they behave very aggressively. So there are the cases that the patients, most of the times, they present with metastatic disease or they have metastasis very shortly thereafter. And there are some cases that have a protracted clinical course. Of course, we don't have a long follow-up, but in our case, it's very interesting that a patient had a mass in 2009. We don't know if they missed it or we don't know if they got it and it was misdiagnosed, but you can see here that it's probably the same tumor because they were seeing a mass of 7 centimeters, and then after 13 years, it exploded, but we have no proof of that because we haven't seen the initial biopsy. So with our experience of these 45 cases, we can say that it looks pretty distinct, and there are some key histologic features that in retrospect, almost all of them were present in our core biopsies. So this combination of round and spindle cells is clue 1. Pseudoalveolar microcystic changes, very characteristic, is clue 2. Fibrous septations, again, very characteristic as well, clue 3. Hyalinized thin wall vessels, they are clue 4, and then the round cells, they don't have this aggressive high-grade morphology that you usually see in other round cell sarcomas, but they have this banal nuclear features, clue 5. Retrospectively, in our core biopsies, 4 out of 5 of these clues that were present. The EWSR1 and PATZ1 genes are located on the same chromosome, the chromosome 22. They're only 2 megabases apart. So that results in an intrachromosomal rearrangement with pericentric inversion. And because of that, the break-apart fish has a low sensitivity, although in our cases detected, but in many cases it doesn't detect it. Then the transcript detection can be reliably performed with RNA sequencing. The most common fusion is between exon 8 or exon 9 of EWSR1 and exon 1 of PATZ1. And that has as a result, a functional change and converses the transcriptional repressor to an activator. There were some initial papers that suggested that CDKN2A/B or MDM2 amplifications may imply a worse prognosis. However, from the data that we have so far from the 45 reported cases, seems that these concomitant mutations do not correlate with poor outcomes. Both indolent and aggressive clinical behaviors have been observed in tumors that they have CDKN2A/B or they don't have CDKN2A/B mutations. The differential diagnosis in general is broad, but most of the times you can exclude Ewing sarcoma, desmoplastic round cell sarcoma, B-core, CIC. However, I think that the most important differential that you can be misled, and of course we're misled, is rhabdomyosarcoma, since this is diffusely myo D1, and a myopithelial tumor, since this tumor stains for myopithelial neoplasms. But of course, myopithelial tumor would not be positive for myo D1. And of course, the presence of the fusion will exclude the types of rhabdomyosarcoma that we accept so far. Now, whether this entity represents a single entity defined by this molecular event, whether it represents more than one tumor type that harbors identical gene fusion, or possibly even a distinct subtype of fusion-driven rhabdomyosarcoma is not entirely clear. But however, from the 45 cases that have been reported, we can say that it looks distinctive morphologically and immunohistochemically, and it probably represents a single entity. Now, if we're going to put it as a distinct entity or a subtype of rhabdomyosarcoma, that is to be seen. However, it's interesting to say if we have identified these common morphological features before the NGS era, we probably would have put it in a rhabdomyosarcoma subtype. But of course, MPNST with rhabdomyosarcoma, this differentiation, we don't call it rhabdomyosarcoma. And this was the case, and I hope you enjoyed. This is my email. This is my Twitter account. I tweet only for medical reasons. And this is my YouTube channel where I put all my lectures. And please subscribe to have access to additional lectures there. Thank you very much.